Muy buenas noches a todos, bienvenidos de nuevo, o tardes en Sudamérica. Continuamos con el módulo de epilepsia y disquinesias y con la última clase tenemos el honor de presentar nuevamente al doctor Paul Mandigers, que va a estar hablando de desórdenes del movimiento. Welcome, Dr. Paul, again.
Thank you.
Okay, you can share your screen when you want, and the auditory is all yours.
Okay, tonight, for me it's tonight. Today we are going to talk about movement disorders. And actually this might be a bit of a challenge if you want to cover it in 1 hour, because it's a huge subject. If you're talking about movement disorders in humans, you can buy 3-4 large volumes of books, all talking about movement disorders. So what I will try to do is cover the basics, that you understand the difference between epilepsy and a movement disorder, and that you can sort of deal with it. The reason why we know something about movement disorders has all to do with this guy, because he invented the iPhone. This is, I think, still the iPhone 3, so that's ancient. But when he invented this iPhone, people were able to record what their animal, their dog, their cat, was actually doing. And prior to this, owners gave a description. And if an owner, for instance, is saying, well, my dog was laying on the floor and he was stiff and he didn't respond to me, then it could be, for instance, epilepsy, but it could also be, for instance, a movement disorder. And thanks to the iPhone, it has, well, at least thanks to the smartphone, it has improved our diagnostics. And that's for humans and veterinarians, because it's the same for humans, of course. Now, before we are going to talk about movement disorders, I would like to address the pyramidal and extrapyramidal system. And this is to understand the concept of a movement disorder. Now here you can see a Chihuahua, and this Chihuahua has basically no brain. He has a severe hydrocephalus, but the dog is still able to walk. He's stupid. He doesn't know how, he's not house trained. He is not able, they are not able to do anything with him, but he's still able to walk. And that has to do with the fact that all the tracts are still intact. When we are talking about walking, when we are talking about a movement disorder, then you have to realize that there are two basic systems that make it possible that we are able to walk. And that's the motor system, divided in a motor cortex, which is actually using the tractus corticospinal, or the corticospinal tract, and that moves from the motor cortex to the brainstem to the spinal cord. And there is the premotor cortex, and that's actually the system what we call extrapyramidal system, which is actually going from the premotor cortex to the basal nuclei to the thalamus, and the thalamus communicates with the cortex. So these two systems, these are actually responsible for the fact that we are able to walk. And if something goes wrong here, and it's mainly in this system, then you get a movement disorder. Now the tract, the pyramidal tract, that's actually the one where you have this beautiful projection of your body on the motor cortex. And it's actually a very simple system. Well, it's not simple, of course, but that's the motor cortex, the spinal tract that goes to the other side of your body. And that's what we call the corticospinal tract. So from the cortex to the spine, to the, to the myelin located in your spinal part. Important to remember, what is starting on the left side goes to the right side, and what starts on the right side goes to the left side. Okay, it's a very simple system. Well, it's not simple, of course, but it's basically a sort of simple system. But if something goes wrong, then you can see something. Like, for instance, if there is, and I will move quickly to this part. Let's say that you have an infarct here, then this part of your body is immediately not functioning anymore. But if this would be the right cortex, it's the left side of your, no, that's what I'm saying now incorrectly. So, well, sorry. So let's say that it's located here. So you have an infarct here and it's on the right side, then it's on the left side where it's actually not functioning anymore. So that's the first part of the system. And if, for instance, there is something like an infarct, stroke, or whatever, then at first it's a flaccid paralysis, and after time it becomes more spastic. Okay. Now I already said it, there's also the other system, and that's actually where if anything goes wrong here, then we start seeing all these movement disorders. And it has all to do with the thing, the thalamus. And I always say the thalamus is actually a sort of, well, it's a sort of egg located in the middle of your brain. And it's actually composition of 30 nuclei. And it's actually, you should say, a sort of chihuahua, because the thalamus is always wanting to do something. It's always sending out impulses to do something. And what you at the moment are doing now is that you're actually suppressing your thalamus. Otherwise you would move, otherwise you would do something. But the thalamus is actually a very important thing if we want to move. And you could say it's a sort of gateway to the cortex, because the thalamus receives information from the spinal cord, vestibular system, the cerebellum, etc. So the thalamus is actually a very important part of our complete movement process. Now, I already said it, if there is a movement disorder and it's the extrapyramidal system, then it's actually then the dysfunction is actually based here in these basal ganglia and the thalamus. And there are actually two actions if we are talking about the premotor cortex system. The first action is that you would like to move, and the other system or the other action is that you don't want to move. And to move is the direct path, and not to move is the indirect path. Now, this is a schematic presentation of actually the system. So here we have our motor cortex. And if the thalamus is actually saying to the motor cortex, do something, then there is movement. So the muscles are actually stimulated to do something. Now, to move, you need actually a system, and that works from the motor cortex. So that's the premotor cortex part. There is actually stimulus to the striatum, and there are a number of basal ganglia located here. And they actually have used GABA, which is inhibitory, and they stimulate two systems. And then actually the thalamus is suppressed. And that means that if the thalamus is suppressed, no, I'm saying it incorrectly. You are suppressing the fact that it's not able to stimulate, and then there is action. So that's when we want to move. Now, if we want to regulate, it's actually using a different system where you actually inhibit the thalamus. And then there's no movement. And everybody knows the word dopamine. And if you are talking about, because this is a regulation system, if we are talking about, for instance, a shortages of dopamine, then it's actually what you are getting is that this system, if the dopamine is not there, the system doesn't function anymore. And a beautiful example of this is Parkinson's disease. So Parkinson's disease is a movement disorder, which is actually caused by a shortages, I can't pronounce the word, sorry, of dopamine. And that's the reason why the complete system doesn't function anymore. Now, if we are talking about movement disorders and we are talking about tremors or paroxysmal disorders or these cramps or tics, then it's this system which is actually not working correctly. Now, what are the characteristics of a movement disorder? First of all, it's something you do not want to do. So it's an involuntary thing. And it can be episodic or persistent, depends on, of course, the movement disorder. Because, for instance, if you're in a late stage of Parkinson's disease, then it's a persistent movement disorder. But for instance, a cramp can be a very short episodic thing. Now, and these movement disorders, they can suddenly be there and disappear, which is actually paroxysmal. That's what it means. And it can be during activity or not. But a very important hallmark is that there is no loss of consciousness. And that's a big difference with, for instance, a generalized tonic-clonic seizure, because then there is loss of consciousness. Now, and another thing is, if we are talking about the difference with epilepsy, I already said it, they are extrapyramidal, cerebellar, or they are, and that's the cramps, etc., peripheral. We are conscious, and a lot of movement disorders last longer than, for instance, epilepsy. And that's again a big difference because epilepsy, there is an pre-ictal phase. You can see that something is going on. It's not always there. Then there is the ictus, and the ictus itself lasts for, let's say, 1 to 3 minutes. And then there is the post-ictal phase. And with a movement disorder, it's suddenly there and it's suddenly gone. So there's no pre-ictal or post-ictal thing. Now, and these movement disorders, you could basically say it's either something that has to do with either a neurotransmitter or receptor, or for instance, an ion channel. And there something goes wrong. And that's again a big difference. With epilepsy, it's actually an electric storm in your brain, which is causing a dysfunction of the complete system, so your motor system, your sensory system, as well as your autonomic system. And with a movement disorder, it's just one thing that's actually not functioning anymore. Just one. Now, this is a very schematic presentation of how you could deal with movement disorders, and we are going through it during this hour. Movement disorders can be pyramidal, so that's the infarct. It can be a basal nuclei problem, and then it can cause either hypokinesia or hyperkinesia, or it can introduce something strange like restless legs, you must have heard of it, or compulsive disorders, or menace, so the fact that you're, for instance, constantly clipping your hands. And there is, of course, the part where the cerebellum is dysfunctioning. Now, these movement disorders, you can buy, let's say, 10 different books, and they all use different classifications. And that's a bit complicating and, of course, disturbing, but basically, they are all right. For instance, this is another classification where they say, okay, you have movement disorders. So there is the cerebellar part, this is the pyramidal part, this is the part where the basal ganglia are dysfunctioning. And they say there is also the Parkinsonism. So that's a slightly different classification. And there is, for instance, this one, and there is this one. But basically, if you want to keep it simple, just memorize, if we're talking about a movement disorder, then there is the true cerebellar disease, there's the basal nuclei problem, and there's the pyramidal system problem. And they can be subdivided, if we are talking about basal nuclei, in hyper, and of course the strange movement disorders, and the hyperkinesias. They are subdivided in different words, and that's all what you could say. Yeah, it comes from history. It's a thing we have to live with, because it's not logical. Not sometimes it's not logical anymore to use these words. Now, what we are going to do tonight, or this day, we are going to talk about the tremors, that's cerebellar, and the things that go wrong in your brain, and the things that are peripheral. Now, if we are talking about all these beautiful things, then there are a lot of words we can use to describe a movement disorder. And just sit down and don't memorize this, because it's just sort of explaining how complicated we have made it for ourselves. For instance, this is atheosis. So you can see here this hand, it's not moving correctly, but there is still something like a writing movement. There's still something like a sort of logical movement. Now, another one is this, for instance. This is ballism. This Scottish Terrier, you can see that he's jumping very strangely, which shouldn't be the case. But this is what we call ballism. This is chorea, and chorea is beautiful Greek for dancing. So this is chorea.
Okay. Yes.
And this is also chorea. So what you see is that she is not doing this voluntarily. Yeah? This is what she is doing. But you can see that it looks a bit like the French bulldog. There's a dancing movement, chorea. And this is chorea atheosis. So it's a combination of the atheosis and a combination of the dancing. So here you can see that it's more severe. You can see the atheosis, but also the chorea. And the cramping. So this is Scottish Terrier with Scotty cramp. And this is dystonia. And dystonia means that you're not able to keep your tonus. That's what it actually means. So it's just a way of describing an abnormal movement. Now, this is, for instance, a fasciculation, and that's a group of muscle fibers that's contracting. So that's a fasciculation. And here you can see this beagle with a spinal cord problem. It has a cervical disc problem, and it has developed these fasciculations. And this is a myoclonus. So this is not myoclonus due to distemper. No, this is a myoclonus due to, well, another thing. This is a distemper myoclonus. And a myos is, myos means muscle in Greek, and clonus means, of course, that you have a sudden contraction. So this is a myoclonal way of walking, and due to distemper, in this case. And you can develop a myoclonus due to propofol use. It's also a very big differential diagnosis. And this is, for instance, myokemia, and that's a sort of rippling. So if you look at these muscles here in this Jack Russell Terrier, then you can see that there is actually a sort of rippling of these muscle groups under his skin. And he's now not able to walk, And there is this myokemia visible, and it's also in the hind leg. And this is also myokemia, or you could say this is actually a sort of, yeah, dystonia, myoclonus.
August 29th.
And this is a neuromyotonia, so a contraction of all his muscles in his limbs, and that's what we call then a neuromyotonia. And this is tetanus, so he's not moving at all. And this is, for instance, an idiopathic head tremor. And to make it even worse, this is hyperkinesia. So this is a paroxysmal dyskinesia. So this is a Labrador with sudden onset of stiffness of his legs, not able to walk. So it's a hyperkinetic movement disorder, and we call it a paroxysmal dyskinesia. Oh, yeah. And this is bradykinesia. So it's a very slow abnormal movement. They also call it, because it's a thing we see in English bull terriers, they also call it trancing bull terriers. And this is a tick. The dog is not doing anything, so but what you would see is that he's suddenly moving with his head, so a tick. And this is what we call manners. So for instance, this constant licking, stereotypic abnormal behavior could be a sort of movement disorder. And this is also manners. So when we are talking about movement disorders, the sad thing for everybody is that we are using a lot of old words, all derived from Greek and Latin, to describe what we see. And that's one of the reasons why we as a group said, okay, this should be done differently. And that's why we published a number of papers on a different way of classification. Now, let's talk first a bit about tremors, because that's the easy part. If we are talking about tremors, that means that there is a rhythmic tremor of a part of the body or the complete body, and it's always at the same frequency. Now, these tremors, we can subdivide them in resting tremors, and that's actually Parkinson's disease. We don't know it in veterinary medicine. And we can say there's an action-related tremor, and then there is the kinetic tremor, which is actually due to a problem of the cerebellum. And then there is the postural tremor, and that has to do with the fact that it's related to a postural thing. So an orthostatic tremor, for instance, that's a tremor that's visible when you're standing, because then there is the postural system is active. And that's the same with a head tremor, because the moment you lift your head, you need to contract muscles in your neck, otherwise your head would fall down. And that's the reason why we call it a postural tremor. So if we are talking about tremors, we divide it in a resting tremor, we don't see it, an action related, and that's either kinetic, cerebellum, or postural. Now, an example of the resting tremor, and that's Parkinson's disease. So this is a resting tremor. The tremor is already there during while he is at rest, standing, and it all has to do with dopamine. Now, Parkinson's disease is a neurodegenerative disease that's affecting, in the end, the complete brain, but in the beginning, there's only dopamine shortage, and then you are not able to regulate your normal locomotion. Oh, okay. So there are also in veterinary medicine, we are talking about the action-related tremors, and then there is the postural tremor, And the biggest example of it is the orthostatic tremor. And that's, for instance, a thing we see in the Great Dane or the Newfoundlander. So when the dog is standing, he develops the tremor. When he's walking, he doesn't have the tremor, because at this moment, he has to use his postural system. Now, it's a thing we see often in the giant breeds, Great Dane, Deerhound, Newfoundlander. If it's a young dog, and if it's only of one of these breeds, and it's only visible when the dog is standing, then that's a typical orthostatic tremor in these breeds. These tremors, when are they a problem? Well, to lay down, you need to relax. Just imagine that you want to sit on a chair while you contract all the muscles in your legs. Then it's not possible. So the dog is able to walk, then the tremor is gone. But the moment he's still standing, the tremor appears. And the problem for the dog is that he's not now, it's very difficult to lay down. If he lays down, if let's say that he's able to do it, then again the tremor is absent, because the whole thing is the tremor is only visible when his feet are on the ground, because it's an action-related tremor, a postural tremor. So if I lift the leg and if I stimulate the paw, then the tremor should develop. And then so now it starts. So there the tremor is. And if I, for instance, only lift the leg without touching the paw, then the tremor is not there, because it's a dysfunction of the postural system. Now, these action-related postural tremors, so a hallmark is they disappear when walking. They disappear when they are laying down. So that's a difference. If you see, for instance, a tremor in a dog that's laying down, then it's something else. If you would be able to make an EMG from such a tremor, then it's like soldiers marching in a group. So it sounds like soldiers marching. Okay, if a dog is really severely affected by such a tremor, then we try to treat it. It's always trial and error with, for instance, gabapentin, phenobarbital, or one of the benzodiazepines. A similar tremor is the idiopathic head tremor. And you could say this is, well, I think cerebellar diseases are the most frequent, but if we are talking about the second one, then it's the head tremor. And it seems, for me, it's in most cases something like a bulldog type of dog, but you see it in Labradors, you see it in all kinds of dogs, and it can be a vertical or horizontal tremor. And it again disappears when the dog is distracted or when he's walking, for instance, etc. And it's a tremor with always the same frequency. So here is a horizontal one. And this is, for instance, also horizontal. And this is also horizontal. Now, these guys are always young dogs. And that's the reason why we think that it might be, because it's always something like a bulldog, French bulldog, blah, blah, blah. So we think that it might be a breed-specific sensibility for, let's say, an infection. But the nice thing for the owner is, let's say that you see a head tremor, you can say that it, in most cases, resolves by itself. You don't need treatment. And if you would need treatment, then, for instance, if let's say that you're prescribing an NSAID, it could be that the NSAID is not doing anything, but the dog will the tremor will disappear in 2 to 3 weeks by itself. But it's a tremor with a good prognosis. The only thing is, let's say that a similar tremor exists in an older dog, then the advice is to perform at least some kinds of diagnostics, like for instance an MRI. Because recently I reviewed this paper and they described 100 cases with a tremor, and those dogs that were older, then in most cases they found something structural in the brain. And if it's a young dog, you often find nothing. Now, there's also the older dog that's developing a tremor when standing on the table. So this is an older Malteser dog with this tremor. And that's what we sort of call an essential tremor or senile tremor or physiological tremor. If it's an older dog, it's there. Yeah, we don't know what the etiology or pathogenesis of it is. Just say the dog won't die from it. It's just there. It's a tremor we develop as well. Because this tremor, this physiological tremor, exists in 50% of all people older than 50 years of age. So it's a normal thing. So if you see, for instance, an older person with a tremor of the hand, yeah, that's life. That's what happens. So this is a normal, well, it's a senile or benign essential tremor. Then we have also the tremor where it's a kinetic tremor, and these are the cerebellar tremors. And we already talked about all kinds of genetic disorders that are causing all these cerebellar diseases. And this is this group, for instance. So when you see, for instance, a young dog with a cerebellar tremor, you're not saying, it's a movement disorder. You call it ataxia, cerebellar ataxia. But of course, it's in essence a movement disorder. And we already sort of said something about it when we were discussing all these genetic diseases. But this group is a very large group because we have a huge number of mutations causing these cerebellar degenerations. And that's actually what is written down here, that some of them are hereditary. Some of them can be metabolic, toxic, inflammatory. It's all possible, of course. And that's the reason why you do your basic workup. For instance, if you have a complete litter with a tremor, then something is going wrong there. It could be an infection, could be medication, etc. And if we are talking about the cerebellar diseases, I already said it in the previous presentation, there are many breeds that are suffering from this type of tremor. And this is, for instance, the tremor of the husky. And it looks like this. So this is actually an example of such a disorder. Now, one of the first movement disorders ever described was actually, the first was actually Scotty cramp. And when they described it, they called it Scotty cramp. And why? Because it was visible in a Scottish terrier. And the other one, the second one described, was the white dog shaker syndrome. And that was actually because these dogs were white. And at this time, they didn't know what it is. And they treated it with corticosteroids. And because they responded, they thought it might be a sort of immune-mediated meningoencephalitis. But this is described in the period prior to MRI. But this white, hairy shaker syndrome has all to do with the fact that they are just white and developed this beautiful tremor. If there are questions at this stage, we can do it, but maybe it's better that we continue because the time is short, of course. So I will continue because you have survived now the first part, the tremors, and how these movement disorders arise. If we are talking about movement disorders, you have the rhythmic ones, and that's the tremors, and you have non-rhythmic ones. And that's, for instance, the biggest group is this group, the paroxysmal dyskinesias. And actually a dystonia is just a clinical sign of a paroxysmal dyskinesia, but we sort of kept the word. And then there is this group of cramps, twitches, and spasms, and these guys are all, in most cases, peripheral. If we are talking about paroxysmal dyskinesia, it's already said. Paroxysmal means it's suddenly there and it's suddenly gone. Kinesia, movement. This, you're not able to do it. And these paroxysmal dyskinesias, well, a very important thing to mention to an owner. So let's say that you have diagnosed in the Labrador, this is an example, the fact that he's suffering from a paroxysmal dyskinesia, then you can say to the owner, it's in principle self-limiting, it's painless, and he doesn't die from it. The only thing is that if this would last for, let's say, an hour, then there is, of course, a phase that he needs to recover. But in essence, it's suddenly there, it's suddenly gone, there's no post-ictal phase, etc. And if it's only seconds, well, we don't tend to do anything. If it's hours, then we tend to do something. Now, I already said it, we described this, so we published about how we deal with these dyskinesias as a group. And I'm actually now writing a third review because we already wrote this. And with a resident of mine, we wrote a paper on dystonia. And now I'm writing with Mark, Laurent, and my resident a third paper where we do a review of all the dyskinesias that have been published so far. But what we basically say is if there is dyskinesia, then this system dysfunctions. And what we basically say is it could be, and this is already said to you, I already mentioned it, it could be an ion channel, or it could be that the neurotransmitter is abnormal or the receptor is not functioning properly. And I click, yeah, this one, I will show the other slides in a few seconds. This is what I wanted to say. And this is what we basically said in this first paper. If we are talking about paroxysmal dyskinesias, they are either hyper or hypokinetic. They are either paroxysmal, so suddenly there, suddenly gone, or persistent, and they can be related to exercise or not. And this is actually, if you just keep this in mind, then you can always deal with them. So let's go back. Now there is always the discussion, is there an overlap in paroxysmal dyskinesias and an epilepsy? Well, most likely there is. Epilepsy means that the complete brain is not able to function, or at least part of the brain or the complete brain. And it is dysregulation of the autonomic, motor, and sensory system. And a paroxysmal dyskinesia means that there is only one thing going wrong. For instance, if you look at this lady, she's laying in bed, and what she's doing is this abnormal movement. And this could be a movement disorder, but in this case, they made an EEG and they diagnosed it as a focal epilepsy. So what she's actually suffering from is a focal epilepsy. But we are now at this moment performing a genetic study in Labradors, where we are zooming in on epilepsy, focal epilepsy, and paroxysmal dyskinesias, and there is an overlap. So some of these systems are actually in both diseases or both disorders dysfunctioning. Now, and another example of such a dyskinesia is this. This is a Cavalier King Charles Spaniel, and it's actually now, you can say this is a sort of dystonia, but it's suddenly there. So we call, he's not able to walk properly. So it's a dyskinesia, suddenly there. So it's a paroxysmal dyskinesia. And in this case, it's actually episodic falling in the Cavalier King Charles Spaniel. And they already found a mutation of this disorder. So in principle, the disease is gone. Now, I already explained it to you. Well, when I started this presentation, I said to you, this is a bit of a challenge because you have to survive me for an hour, and I have to squeeze in things that are in volumes of books in 1 hour. So that's extremely difficult, and we are constantly using all these strange words that are sort of logical and not logical. But if we are talking about paroxysmal dyskinesias, I already said it, then just memorize it's either hyper or hypokinetic, it's either paroxysmal or persistent, and it's either related to exercise or not. And if you are subdividing it then in a bit more complicated terms, then you can say that we are talking about a paroxysmal kinesiogenic dyskinesia, and that means that it is related with movement, or it's non-kinesiogenic, and then it's not related to movement, so it occurs at rest, and it can be an exertion-induced dyskinesia. So let's say that you are after this hour extremely fatigued, then it could be that you develop a brief moment of paroxysmal exertion-induced dyskinesia. For instance, that your eyelids are moving or cramping, for instance. Now, this classification is based on what we see, but you can also do it on how it's caused. And for instance, if we are talking about all these genetic dyskinesias, then there are all these large numbers already published. It's either a receptor or it's a transmitter, etc., etc. So these guys, then you will never find anything, but you have a genetic disorder. And there is, of course, the group with a pathology, because you can develop, for instance, a movement disorder due to a brain tumor, or, for instance, an inflammatory process. That's possible. Now, in the first paper, we already described a huge number of these different movement disorders. In our second one, we added a number of movement disorders. And in the third paper we are going to publish, it will be a summary of all these guys. Now, I can show a few of those just to give an impression. I already talked about episodic falling in the cavalier. So that's actually a paroxysmal dyskinesia caused by a mutation, and it's a breed-specific mutation in the cavalier. We have a paroxysmal dyskinesia, for instance, in soft-coated Wheaten Terrier. We have described one in Shetland Sheepdog. I've described one in a Dutch breed, and we are working on the Belgian Shepherd, and we are working on the Labrador Retriever. But what it, and I will just say something about the Cavalier because it's a nice example. This is a non-kinesiogenic dyskinesia. Young dogs, it's and this is not logical what is written here, triggered by excitement or exercise, because then it's of course a kinesiogenic dyskinesia, so the end should be absent. Sorry. But it's actually a number of these cavaliers, when they get affected, then they can the disorder can disappear by itself. Some of these guys need treatments, and then we either use benzodiazepines or gabapentin, or for instance acetazolamine. But in essence, it's always self-limiting. And I always say to the owners, if there's a trigger and you can avoid the trigger, that's the best treatment you can do. So for instance, if you have a cavalier with this disorder and it's there when they are throwing a ball, don't throw the ball. That's the most simple treatment there is. Now, and another one is, for instance, this one. So this is a soft-coated Wheaten Terrier, different from the Cavalier, but it's still a paroxysmal dyskinesia. And again, same treatment. I've described one in Marquisius, but this is actually a lethal one, and it's lethal because these puppies are not able to walk and they didn't respond to treatment. And that's the reason why they got they were euthanized, or they get euthanized, but we found the mutation, so it's not there anymore. So here you can see a pup, and he's not able to walk. So he cannot do anything, and that's the reason why these owners elect euthanasia, because this is, of course, not a life for a dog. And there another example, that's the paroxysmal dyskinesia in the border terrier, and it's actually the etiology is partly based on a gluten sensitivity. And how does it look like? Well, it looks a bit like the other ones, but this is an example. So you can see this is actually a sort of dystonia. He's not able to stand, walk, but it could be that he's walking and then cramping. And the first time they described it, they called it Spike's disease. And the reason was that the first dog that developed it was actually a dog I saw, and it was called Spike. Afterwards, we called it canine epileptoid cramping syndrome. So we didn't truly know whether it was a extreme, well, it had to do something with epilepsy or not. And nowadays we say it's a paroxysmal dyskinesia. So there are a huge number, and we are now working on, for instance, the Labrador. In these guys, there are a number already published and with mutations. And of course, there's the Scotty cramp. So I cannot show all these guys, but this is, for instance, the paroxysmal dyskinesia in the Labrador. And this is not related to exercise or excitement, but it can be a trigger, but it can also suddenly be there out of rest. And here you can see, for instance, a dog, and that's standing in the garden. And in this case, it was a dog that when he got the attacks, he was standing there for hours. And it took the owner a bit of time to realize that there was something wrong with the dog and that he was not freezing because he saw a rabbit or so. And here you can see another Labrador with, again, this paroxysmal dyskinesia. And this is the reason why we want videos, films, MP4s, whatever, because if an owner would describe this and the dog would lay down, then the owner could describe it if it was epilepsy, but this is of course not epilepsy. This is something completely different. And that's the reason why we say film it. No film, no proper diagnosis. Now, and the last example of such a paroxysmal dyskinesia is Scotty cramp, and I already explained it. This was the first one ever described, and here you can see this Scottish terrier cramping with his right front leg. And this is another example where he's not moving at all. Now, when I got invited, they said, we would like you to talk about movement disorders and treatment. And I thought, okay. No, they said diagnostics and treatment. And I thought, okay, if it's genetic, then there is diagnostics. If it's not genetics, then you need to recognize it. And that's, of course, training. And if we are talking about treatment, well, of course, there is a bit of treatment, but actually treatment, if we are talking about paroxysmal dyskinesias, then it's basically, if you can avoid the trigger, do it. Because let's say that the dog is only having an event of a paroxysmal dyskinesia once every 3 months, you are never going to treat that. If it's only there for a brief period, then the advice is don't do anything. So what we actually said in our paper, if you can find the trigger, avoid it. If not, well, there's no harm if you put them on a gluten-free diet. And if you can live with it, then it's quite simple. Get used to it. Don't do anything. Because if you need treatment for something that's only there for once every 3 months, don't do it. Because then the side effects of the treatment are much more severe than all the other things. But a take-home message, if it's related to movement, Then you could try, for instance, phenobarbital and gabapentin. If not related to movement or excitement, then you could try, for instance, clonazepam, diazepam, or acetazolamide. This is a carbon anhydrase inhibitor. So that's used in glaucoma treatment. And if it's exertion induced, then there is no treatment because avoid the exertion. But this is only done if it's really, 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 really necessary. So you have survived now the second part of this presentation. And what we discussed so far is that these paroxysmal dyskinesias, self-limiting, suddenly there, you're not able to do something, it's painless, the dog is conscious. Of course, it's sometimes difficult to recognize this, and it can last for seconds to hours. Well, and a very important thing is it's often breedly related. And a very important thing is, sorry for that, is that differentiate from epilepsy. Because for instance, if it's a non-kinesiogenic dyskinesia, then phenobarbital most likely will not do anything. And if you're talking about epilepsy, then of course, phenobarbital is one of the things we would like to use. Now, to finish it up, and then you have survived it, we have talked about the tremors, the paroxysmal dyskinesias, and now we are going to say something about the cramps, twitches, and the spasms. And these are actually the peripheral ones, not always, but in majority, the peripheral ones. And the words we are using for these guys are these very ancient words like the fasciculations, the myokemia, the neuromyotonia, and of course, all the other ones. But in essence, we already talked about these guys. So the kinetic tremors. If it's this group, then it's mostly presenting like this. And it has to do with the fact that they are affecting the peripheral nerve system. Now, what's an important differentiation with a cerebellar disorder, for instance? The frequency varies. In a cerebellar disorder, the frequency is depends on the disease, but it has a fixed frequency, and it's not there is not an abnormal movement of the complete body. It's only so, for instance, if we are talking about myoclonus, well, I can show it to explain it, then I can better show it like this. So if we are talking about fasciculations, so that's a brief spontaneous contraction of a small group of muscle fibers. So that's this. This is a French bulldog with or either syringomyelia or it has a disc problem, but there you can see these fasciculations. And that's not rhythmic. So, and it's not causing a movement of his complete body. It's only this part. And this cat you already saw. And here the beagle you already saw it as well. And this is, for instance, the French bulldog. Here you can see the MRI with severe syringomyelia, spinal cord with this syrinx visible. And this French bulldog developed based on these fasciculations. Now, myokemia, we already discussed it. Myokemia means that it's, again, a focal area of muscle fibers that are contracting, but now it's like either like a worm crawling under the skin, a rimpling under the skin. And this Jack Russell Terrier you already saw, so I will skip it in the interest of time. And here you can see a very severe form of myokemia. So this is very, and you could say, hey, but it resembles a bit like a myoclonus. Yes, and that's the reason why we said these are very difficult words, because if we are talking, is this a fasciculation or myokemia, or is it a so, but this is actually due to a severe problem in his brainstem. And here you can see, so look at his head. So this is actually a sort of facial myoclonus. And that means that something is going wrong in his brain. And in this case, I did a full workup, MRI, etc., and never found anything. So that's possible. And these myochemias again have a very specific, so it's again these soldiers. Now, neuromyotonia means that's actually a combination of myochemia, but that's so severe that there is a complete contraction of the complete body. And that's this, for instance. So this is a Jack Russell Terrier that at first had myokemia, and in the end it developed a neuromyotonia. So the dog was walking and bam, there he again went. Now, and another form of peripheral this nerve problem is, for instance, the cramp. And now we are slowly moving to diseases you already know, for instance, tetanus, because tetanus is actually the same. It's a cramp, but it's a constant cramp. And this one, yeah, this is, so here you can see this is actually a case with tetanus. Now, these peripheral nerve problems, they are quite a challenge, because if they are already described, it's what I told to you when talking about genetic diseases. Google, see whether it's a breed where it's already described. So for instance, if you have a Jack Russell Terrier and you see myokemia, then you just have to Google, and then you will find that there are over 10 publications describing myokemia and Jack Russell Terriers. And you will find that there are a number of papers on treatment, number of papers on how to diagnose it, etc., etc., etc. But basically, you could say if we are having something that resembles a peripheral nerve problem, then you always have to do your normal workup, so your physical and your blood examination, and you have to Google if you don't find anything, and then it could be that you're sort of stumbling on the disorder itself. So, and I already said it. So, for instance, if we are talking about these fasciculations, which is a peripheral nerve problem, it could be a spinal cord problem, for instance, and it could be, for instance, a disc problem, or for instance, something like a nerve lesion, nerve tumor. It could be this myokemia, people that undergo radiotherapy might develop afterwards myokemia. And of course, there is this group of brain lesions. So it deserves a normal full workup. But this is, and I'm sorry that I'm sort of giving everything at the same time, but that's what they asked me to do. So I feel sorry for you. But you could say, let's say that we are facing fasciculations, cramp, myokemia, or neuromyotonia. If it's focal, then you have to perform this type of diagnostic. Is it generalized? Then you have to perform this type of diagnostics. So generalized, then it's logical to do blood examination. If it's focal, not. If it's focal and it underwent radiotherapy, bam, your diagnosis is already there. If it's focal and if it's, for instance, legs, then you can perform the EMG, etc. And it might be that you're suddenly diagnosing it. And it could be, for instance, a spinal cord problem, etc. If it's more facial, like the dog you saw, the pointer type of dog, then again, it's more logical to do the brain research. And if it's generalized and your blood examination doesn't reveal anything, this is the moment you start Googling, because it could be a genetic disorder. And if you don't find anything, and it's, for instance, very rare presentation, it could be that it's an immune-mediated channelopathy. But yeah, it's Not always easy, but it's possible. Now, what did I talk about? And I really don't know whether it's already an hour or 1.5 hours. I really don't know, so please excuse me. Well, what I try to explain is that movement disorders are in most cases due to either cerebellar problems, then we are talking about the tremors, or it's the postural syndrome, so or static tremors, or it's the um, disorder of the basal ganglia, so it's the extrapyramidal system. So then we are talking about these guys. And if it's peripheral, then we are talking about these guys. And that's a way of dealing with these movement disorders. And this is actually the end. And if you have questions, then I'm happy to answer them. I give the floor back to
Okay.
you.
Thank you very much. We don't
Just an
have
hour.
questions yet. Yeah, perfect.
Thank
Perfect
you.
timing. Also, it's no problem is it takes a little bit longer, but it was perfect. So we're going to wait if there is any question. We don't have any yet. So just for clarify, when you receive a dog with maybe, for instance, proximal dyskinesia, and it's not a breed in which you have a genetic test, what you do for your diagnostic protocol? You make an MRI, a complete blood test.
Yeah. Well, if let's say that it's a Labrador of 2 years old, it has been described in the Labrador. There are papers on it. We are working on it. Then I discuss with the owner that it's the most logical thing to do is to skip the blood examination, the MRI, all these things, and I just take a DNA sample for our
Okay.
research, and then I give the advice: try to avoid the triggers. You might try a gluten-free diet. If it's not very frequent, don't do anything. And in these Labradors, it's possible that it will disappear by itself. But if there is what I call, uh, if it doesn't fit, so it's not completely logical. So let's say that we are talking about a mongrel dog, then I
Mhm.
always do the full workup. So then I advise the owner, let's do the blood examination, if not done already, perform the MRI if necessary, and do all these other things. Because then it could be that there is something actually present there. And if an owner, for instance, if it's an older dog, I will always do it. So it depends a
Okay.
bit on the situation.
Okay. Perfect. There is a question from Franco Lupino. What it says, how in syndromes like tremor syndromes, how benzodiazepines can help?
Yeah, it's more than a benzodiazepam is, of course, a short working drug. So it's not logical to use it in a dog that is constantly having the tremor. That's not logical. So you actually only use these benzodiazepams to stop it when it's there, if it's only briefly there. So if it's a continuous cerebellar tremor, it's not logical to use it. But let's say,
Okay.
for instance, an example is if a dog is having a paroxysmal dyskinesia event, and if it's only 2 minutes, yeah, you don't do anything. But let's say that the owner calls you and says he's already busy for half an hour and it doesn't stop. Then you have to do something. And that's the moment that you, for instance, can use a benzodiazepam, but not for continuous treatment. Then it would be more logical to, for instance, if it's a Labrador with a high frequency, then it's more logical to use acetozolamide.
Okay. 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 We don't have any more questions. So, Doctor, I have to say thank you. It's an honor to me to have you here to us. And I hope we can have you again in a next course, maybe, or a different course. So
Yes,
thank you
of
very
course.
much.
You're welcome. And I see that the famous guy is talking next time in 2 days.
Yes, yes, yes. So thank you very much and good night.
Okay, same to you. Bye.
Bye. Bueno, la próxima conferencia va a ser el día 3 de abril a las 20 horas hora de España. Ya estamos en el próximo módulo, en el módulo de mielopatías. Y vamos a tener al doctor Paul Freeman que va a estar hablando de la fisiopatología y la clasificación de la enfermedad de disco intervertebral. Buenas noches a todos.